There have been four major things happened since this time. Number one, there's been a de-emphasised focus on people with chronic diseases per se, and a significantly increased focus on individuals at risk of hospital admission. And I'll talk some more about that. The system's got much more sophisticated at thinking about risk. Who are these people at risk of admission? And how can we have a proactive identification of them rather than a retrospective identification? This notion of localities and locality clinical partnerships has been introduced. And lastly, there's been a Save 20,000 Bed Days campaign. So I'll just move very rapidly through these four. The chronic care management program, as I described it, was 5 modules focused on people with particular chronic diseases, diabetes, CVD, CHF, and so on. The problem with that is most of these people don't just have a single condition. They have comorbidities. Secondly, there was a bit of a kickback from general practice against template medicine or very high specification of entry criteria and of the model of care. So the program was seen as a bit inflexible. What we found when we audited the program was that we thought we'd specified it and that people were actually implementing what we'd specified. Well, once you got inside the practices, we found that wasn't the case at all. They were doing what they thought was best inside their practice. Patient numbers in the program rocketed, 16,000 as I said, and we were paying for each patient in there, so how big was the volume going to get? And we hadn't thought about exit criteria, so the cost to us was just going up and up and up and up, and patients could have had their risk significantly reduced but still be getting the benefit of all of that free care. For that reason, caps and volumes had been introduced, but that was hugely inequitable because the people who got all the volumes were the practices who'd moved really fast to enrol their patients, and there weren't any extra volumes available for the slower moving practices. And lastly, the focus of the program had been heavily on improving outcomes for those individual patients and in aggregate population health outcomes. The program hadn't been necessarily heavily focused on acute demand management and admissions to hospital, which was the burning platform. So in around 2010, 2011, this program was rethought and it was folded in to be part of a much more generic at-risk individual program with a heavy focus on preventing admissions in the next year. Now, the critical part of that is how do you identify the patients at risk of admission? As I described, we'd done that previously looking retrospectively, people who'd had 4 or more admissions in the previous year. And as I said, being highly admitted in the previous year actually wasn't a good predictor of future admissions. There's been a massive amount of work done on this internationally, particularly inside the NHS, but also inside the US with insurance-based systems who've got a direct financial interest in this subject. So this is just a simplified representation of what a risk stratification model looks like. And it's really the 2 top groups in a pyramid like this that is of greatest interest to a health system. There's a very small number of people right at the top of the pyramid who need very intensive case management, and that's not the group that I'm talking about here. It's this next group down, and how that group can be identified and what the model of care is that is wrapped around them. So what a lot of effort has gone into across the 3 Auckland DHBs is there is a tool called PARR, P-A-R-R, that's been developed inside the NHS. New Zealand's taken that PAR tool and improved it and tested it very heavily for its predictive ability. And that is now what's being rolled out across Counties Manakau. And so it's applied to general practice registers. It's not applied at hospital end, it's applied at general practice registers to predict at a general practice level which of the enrolled patients are at greatest risk of hospital admission in the next 12 months in order to trigger wrapping a package of care around those patients. And again, if there is one thing I would encourage you to think about, it's that, is how does a system in an integrated sense actually identify who are the patients at risk? Identifying at the hospital end is not the most productive way of identifying them. So in a nutshell, what this at-risk individual program is about is identifying the patients you're talking about, providing effective care to them, and through that effective care, maintaining them. Sounds very simple, but what's been done is to boil that down to an individual general practice level, to say is 14% of the population, which equates to 46% of acute admissions. So for an individual general practice then, that means assessing 4 patients per week per FTE GP. Not a massive task, it's doable. Out of that, you then enrol 50% of the assessed patients, which gives you 7% of the total population enrolled in this program. So that's only enrolling 2 patients per week per full-time equivalent GP. It's not an immense task. And if you've designed your intervention right, then you can achieve a 25% reduction in hospitalisations for this cohort of patients, which means 2 patients per month who would otherwise have been admitted to hospital per practice. Not an immense task. So this is about taking the elephant and getting it down to some bite-sized chunks that people in primary care can relate to. So that's the at-risk individual program. Locality clinical partnerships, this is not a program at all. This is a way of working. So Counties Manakau is a big and diverse area. People don't think about things like Counties Manakau, they think about their suburb and their neighbourhood. So this is about dividing Counties Manakau up into 4 localities, wrapping a joint primary care and specialist clinical governance structure across each locality, using the alliance model which some of you may have heard about, and I'll talk some more about that in a moment, which essentially can be thought of as a partnership. Developing some of these locality hubs, locality teams I mentioned earlier, so community nursing, allied health, diagnostics, creating a hub at this locality level, moving to results-based contracting and global budgets, and having these locality clinical partnerships sharing accountability for decision making and for outcomes and resource use. Counties Manakau is moving tentatively to sharing some of the gains and losses that come out of that process, using these metrics of ED attendances, acute admissions and outpatient appointments. What their aim is to reduce resource utilisation by 20% over 5 years. That is hospital and specialist resource utilisation by 20% over 5 years. There's not a lot of magic in this 20% number, but if you travel internationally, everybody uses this number, the 20% target. Save 20,000 bed days. This is all of the other things I've talked about are ongoing. This was a specific campaign. When Middlemore looked at its admissions in the 11-12 year, 12,200 of them were avoidable. That's 33 avoidable admissions per day. Be really interested, Frank, to get a sense of what these numbers mean in your environment. So in the 12-13 year, Counties Manakau DHB ran a campaign. They redefined, instead of saving 20,000 bed days, which meant nothing for the community, they redefined what the goal was. It was giving 20,000 healthy days back to the community. And this was all about collaboratives in an IHI sense, and advancing on lots of fronts through lots of little initiatives where there could be quick wins, running it under a whole campaign banner. But this was about lots of little things that people at the coalface could do to make things better. So there were 13 of them, and over the space of a year, they exceeded the target of 20,000 bed days. And what it did was it allowed people to think there are little things within our control that we can take responsibility for. We're given a little bit of expertise and money from the organisation, and we're given the go-ahead to do it. So these 13 were chosen after going through a dragon's den kind of process, and it was the impact not only on the system but on people working at the coalface was huge. And these collaboratives were, some were just inside Middlemore, some were just inside primary care, and some were joint. It's now 12 years later. In the 12-13 year, acute growth finally dropped below demographic growth. So the population was ageing and growing at 10 to 12,000 people a year. Acute growth dropped below that level. And then in this year, they've had 7 consecutive months of negative acute growth, which is remarkable. But the thing about this, as I said, is this started in 2002. This just gives a sense of how long of sustained effort this takes. But they are now having conversations about closing hospital wards rather than building more wards. And that is a remarkable outcome.